Hello, everyone, and welcome to our July webinar, Combination Aspirin and DOAC Therapy Increases Bleeding Risk. We can go to the next slide. My name is Geoffrey Barnes. I am one of the AC Forum board members and webinar team members. I'm from the University of Michigan, and I'm really excited to introduce my colleague, Dr. Jordan Schaefer, who is a hematologist at the University of Michigan and was lead author on this paper. And he'll be presenting the paper before we go into our Q&A discussion. We have two excellent members of our webinar team, Dr. Arthur Allen, who's a pharmacist at the VA Salt Lake City Health System, as well as Andrea Van Beek, who is a new member to our webinar team. She's a nurse practitioner in the Anticoagulation Clinic at Visalia Medical Clinic in Central California. We can go to the next slide. We do have some disclosures as always, and they relate largely to companies that make anticoagulants or anticoagulation care. So now I'd like to turn over to Dr. Schaefer, who will present the paper.
Thank you, Jeff, and good afternoon, everyone. On behalf of our Michigan Anticoagulation Quality Improvement Initiative team and our co-authors on this paper, I'll talk a little bit about our study on the adverse events associated with aspirin use for patients anticoagulated with a direct oral anticoagulant. So as you are likely aware, a lot of patients are on aspirin. Recent studies show that 25 to 45% of adults over 40 are taking aspirin. Many of these patients without the knowledge of their primary care practitioner or their healthcare team. Indications for aspirin can be, like I said, primary prevention, stable ischemic heart disease, peripheral arterial disease, cerebrovascular disease. It's used in secondary prevention for non-cardioembolic ischemic stroke, for a transient ischemic attack, and is occasionally used for secondary prevention of venous thromboembolic disease. Some prothrombotic disorders also utilize aspirin for thromboprophylaxis, including myeloproliferative neoplasms, some patients with antiphospholipid antibody syndrome. It's used as an analgesic, and again, sometimes used for colorectal cancer risk reduction and in the setting of preeclampsia. So increasingly, there's been interest in, when is the appropriate settings to combine aspirin with an anticoagulant. And so there's data for some patients with mechanical heart valves, for patients after acute coronary syndromes with an indication for anticoagulation, sometimes with cardiac devices such as LVADs, and among other settings. So this is always a question of risk versus benefit. You're trying to balance, thrombosis prevention with the risk of bleeding. And, pretty much most of the data that's out there shows that adding aspirin, whether it be for primary prevention or with an anticoagulant, adds some bleeding risk. Most of the data, to date has been with warfarin and aspirin. And also for the patient context of atrial fibrillation, there's more data than in the setting of venous thromboembolism. Combination therapy is very common. We completed a previous study looking at this question for patients anticoagulated with warfarin in our practice, and found that about a third of patients on chronic warfarin were also on concomitant aspirin therapy. It's been estimated that in North America, hundreds of thousands of patients are on combination therapy with warfarin and an anticoagulant, warfarin and aspirin, or an anticoagulant and aspirin therapy. There is also, still some, continuing exploration of the benefits of, combination therapy. Mechanistically, it makes, sense that for patients with thrombotic risk that you'd target, both the platelets and, factor 10A. There's the COMPASS study, which is, depicted to the right of the slide here, that showed, a very low dose of direct oral anticoagulant with aspirin improved cardiovascular outcomes for high-risk patients, but at the cost of major bleeding events. What we wanted to look at was, the therapeutic dosing of direct oral anticoagulants in aspirin and what that looked like. So in the studies, the direct oral anticoagulants included in our study were apixaban, dabigatran, which is the direct thrombin inhibitor, edoxaban, rivaroxaban. Considering, the previous data on warfarin, we were wondering if the bleeding rates might be lower, with DOAC and aspirin compared to warfarin and aspirin, given that, the DOACs generally have a better safety profile. There have been concerns in the literature, though, that the direct oral anticoagulants might have a higher rate of gastrointestinal bleeding. And so, aspirin, adding aspirin to a DOAC, we weren't exactly sure of the effects in that setting. So our study questions were, how often are patients anticoagulated with a direct oral anticoagulant for atrial fibrillation or venous thromboembolic disease without a recent myocardial infarction or history of heart valve replacement treated with concomitant aspirin? And how does this impact outcomes? And we knew that we would have much more bleeding events than thrombotic outcomes. So our primary, outcome of interest was bleeding, but we had additional secondary outcomes of, healthcare utilization and thrombosis. So we approached this using registry data from the Michigan Anticoagulation Quality Improvement Initiative. This is a collaborative of health systems located in Michigan, represents both urban and rural practices with a variety of patient sizes, a fairly diverse patient group, but again, all located in Michigan. Patients were newly started on DOAC from January 2015 through December of 2019 were included in the registry. We analyzed the data in 2020. This is, very nice and robust data source. It's a difficult topic to study, given that aspirin is over the counter. It's available without a prescription and often dynamic. The data was collected by trained data abstractors using predefined forms looking for our variables. And as part of the MACI process, there's random chart audits done to verify that the data in the electronic medical record is matching up with what's in our registry. So this is just a schematic of the study design. You have patients on a DOAC for AFib or VTE with 3 months of follow-up. We eliminated patients with a recent myocardial infarction or history of heart valve replacement. That left us with 3,280 patients. We wanted to try to look at two balanced, populations. So we conducted a 1-to-1 propensity match, which left us with 1,047 patients on DOAC and aspirin compared to 1,047 patients on DOAC monotherapy. So our propensity match was robust. It matched on patient demographics, age, sex, weight, social history, indication for anticoagulation. We looked at comorbidities, and we looked at their history of bleeding and clotting. So did they have a history of bleeding, history of stroke or transient ischemic attack, history of VTE, GI bleeding, and remote myocardial infarction. We looked at various medications, including non-aspirin antiplatelet therapies. And we also looked at the dose of the direct oral anticoagulant. And we conducted, I'll discuss that later, we looked at both full dose and, half dose of the direct oral anticoagulants. And we matched the patients on follow-up so that we had an equal amount of exposure to potential bleeding events. We calculated a HAS-BLED score for each patient along with Charlson comorbidity index. For our study outcomes, again, we looked at the rate of aspirin use, and we looked at that over time. We looked at thrombotic outcomes, including stroke or TIA, pulmonary embolism, DVT-PE, myocardial infarction. Our bleeding outcomes included various forms of major bleeding, including fatal, life-threatening, and central nervous system bleeding. We looked at non-major bleeding and any bleeding which was allowed to be somewhat patient-defined if they reported an interval bleeding event between their follow-up visits. We analyzed healthcare utilization, including emergency room visits and hospitalizations. Patients were followed at 6-month intervals after the time of enrollment. So this is a study schema, again, looking at the study. This is just to kind of go into a couple of our sensitivity analyses that we did to try to just really understand this data completely. One of the questions was whether or not to match on the DOAC dose. Some patients, for example, with extended secondary prevention of venous thromboembolic disease might be reduced dose. Doses of DOACs might be reduced based on age and renal function or other clinical factors based on the labeling. The dosing may change over time. We followed these patients for over a year. So we analyzed it both ways, both matching and not matching on the DOAC dose. Given that patients may start or stop aspirin during the study period, our primary analysis was based on aspirin use at enrollment. We did a sub-analysis looking at patients that were continuous on aspirin or continuously not on aspirin throughout follow-up. However, you can imagine that if a patient experienced a bleed, they might stop the aspirin, and there can be various reasons as to why somebody may start or stop throughout the study period. And then we wanted to look at the patients that really had no clear reason for aspirin at all and see if the study results differ. That included patients with, essentially we excluded patients with any history of vascular disease. So looking at our study results, over time we found that about 1/3 of the patients were on combination therapy prior to our propensity match. And looking at our propensity matched data, we see that, about 2/3 of patients were on apixaban, 1/3 on rivaroxaban with lesser representation for dabigatran and edoxaban. The majority of the patients were on full dose anticoagulation. So, for example, 20 milligrams a day of rivaroxaban or 5 milligrams twice a day of apixaban. The age was, patients' mean age was in their 70s. You've got gender here, and then it was largely an obese patient population with over 50% having a BMI over 30. The majority of the patients were anticoagulated for AFib or A-flutter. The patient follow-up, the median duration of follow-up was 12 months with the interquartile range of 6 to 30 months. Here you can see that the patients getting aspirin had more cardiovascular disease, kind of as you would expect. Had more, coronary artery disease. And so we weren't able to fully match on all differences. So any residual difference after the propensity match was included in our Poisson regression models. But again, fairly similar for most of the major factors. So displayed to the left here is our bleeding outcomes. This is events per 100 patient years. And so the light shading is patients on DOAC and aspirin therapy, whereas the dark shading is DOAC monotherapy. And you can see the standard error bars here at the top of the histogram. So we have increased any bleeding with combination therapy, and non-major bleeding really kind of drove the difference in bleeding that we saw. You see increased ER visits, hospitalizations on combination therapy, and then we have our mortality outcome. And so looking at thrombotic outcomes, now our axis has changed because there were less thrombotic outcomes. So it's still events per 100 patient years, but the numbers are much smaller. but you see that we did not observe a statistically significant difference in thrombosis outcomes with aspirin. And our overall healthcare utilization was similar. And again, we have our mortality there. So there are some, limitations to the study. It is registry data. There's the chance for confounding variables that we did not capture or adjust for. However, our data was very robust, and as you saw, we matched on numerous variables. We weren't able to match on every single variable, but the residual differences were included in our regression analysis. We did combine both patients with atrial fibrillation and venous thromboembolic disease. We think this is an important question, and we wanted to have power to answer our study outcome. And given that the magnitude of bleeding and thrombotic events is still not, especially high, we did this for power, but there may be differences between these groups. We have some key subgroups that are likely underrepresented. So, there's always concern with the people that are especially high thrombotic risk that may not have been, fully assessed. For example, patients with poorly controlled vascular risk factors, such as poorly controlled diabetes or blood pressure, patients with vascular stents, other, high thrombotic risk factors, for example, hereditary thrombophilias or myeloproliferative neoplasms, among others. It's a topic that, as we gain more data through our registry, we might be able to explore these questions further. We might also be able to look at, differences in each of the direct oral anticoagulants themselves to see if there's any performance difference based on drug. The patient population was all limited to the state of Michigan. However, we feel that it's a fairly diverse group of clinical practices. And so we feel that it's likely representative of a U.S. population. However, there may be some differences there. And our study at this point was likely underpowered to assess differences in thrombotic outcomes. Most of our patients were newly initiated on a direct oral anticoagulant, 71%. So again, one potential question in the future would be the patient that's been stable on a given regimen for many years. While these patients likely have the same, some of the same risks for adding aspirin to their anticoagulation, most of our patients were newly started. So this was a visual abstract that I from 2-Minute Medicine with the link below that kind of highlights the findings of our registry-based study. Ultimately, we concluded based on this investigation that you do have an increase in bleeding for our patients that are adding aspirin to direct oral anticoagulant therapy for atrial fibrillation or VTE. There's definitely a need for more research for high-risk subgroups, and also looking at, the varieties of dosing combinations that can be encountered with the DOAC dose adjustments. And but the study really highlights that many patients are on aspirin with no clear indication, no history of vascular disease or anything else, primary prevention aspirin that never got, discontinued. And, these patients might, the net risk of, that aspirin is maybe more than the potential for benefit for these patients. And so therefore, it's something that we need to pay attention to and consider deprescribing aspirin when the risk is, greater than benefit. And it's something that we're working on through the Michigan Anticoagulation Quality Improvement Initiative. So I'll go ahead and stop for questions there, but I'd also just like to thank all the team members and members of MACI that made this study, possible. And, we're looking forward to continuing to work with this group in investigating these types of questions. So I'll go ahead and turn it back to Jeff here.
Well, Jordan, thank you so much for reviewing that. Really a comprehensive review. For everyone who's attending, if you have questions, please put those in the Q&A box, and we'll try and get through as many of those as possible. I just want to offer a couple reflections before we get into the Q&A session. I really appreciate you leading this effort. It's been sort of a multi-year evolution in the work that we've been doing. Of course, being very focused on anticoagulation care in the anticoagulation clinic, we first started asking this question in our patients who are on warfarin, who are being closely managed by our nurses and pharmacists, and really thinking, is there an opportunity to reduce their adverse event risk? And I think your work from a couple years ago really showed that when warfarin and aspirin are combined and there's no clear indication for aspirin, those patients do have worse outcomes. And so that's led to some QI efforts we can certainly talk about a little bit more here. But it also led to the question of, well, what if they aren't on warfarin and instead are on a direct oral anticoagulant? We know that overall they have lower bleeding risk, certainly lower risk of the most serious types of bleeding in a DOAC treated patient versus a warfarin treated patient. Would we see those same patterns of increased bleeding if they were also on aspirin without a really clear-cut indication? And I think what you've shown us here today is that, yeah, there does seem to be some increased risk of bleeding. It's also important to know that this is a little different than maybe a lot of the large randomized trials where they're looking at patients who are newly undergoing PCI or having acute coronary syndrome. We were sort of looking in more of the chronic phase. And so it's very complementary to some of those other trials. I think in particular about the Augustus trial, which looked at warfarin versus apixaban and use of dual antiplatelet versus just single antiplatelet in patients with AFib and PCI or acute coronary syndrome. So really a lot of data adding up to telling the same story, but I think this is certainly helping us in the outpatient setting, those of us who are trying to care for patients on chronic anticoagulant therapy, and how can we reduce any adverse event risk. Why don't I invite Arthur and Andrea back to the group, and we can go ahead and get started with some of the Q&A. I know we have a number coming in, so it should be a robust discussion.
Excellent. And Jeff and I have talked before. This is an issue near and dear to my heart. I feel like the question with warfarin has been asked and answered historically, and that early on in the DOAC life, we were kind of extrapolating to DOACs. So to do something specific to DOACs, really important work, and I appreciate it very much. I want to start with a question specific to the study. Most of the questions are about this topic. There was one question specific to the study. In patients with a remote history of MI in your study, what was the average time from that MI?
Yeah, so the way our registry was set up, most of the patients were at least 6 months from the time of the MI.
Okay, thank you.
Yeah, thanks for this presentation. I think it's a really important topic. So I manage an anticoagulation clinic, and we often have to deal with seeing patients. They come to us, they're on aspirin, they're on Plavix, they're on a DOAC, they're on triple therapy. What's a good strategy for our followers to discuss with the cardiologist managing the patient, or do we as an anticoagulation clinic make this call about when to de-escalate therapy? What's your experience with?
Yeah, that's a good question, and it's something we've been working on through Mackie, especially on the warfarin treated patients where we had the initial set of data. And, our approach was really looking at the low-hanging fruit where, kind of there's this broad agreement that this patient shouldn't be on aspirin. So, one of the first steps in that is asking patients, there's always, continuously, I've been, obviously very vigilant on this issue in my clinic, and, it doesn't end up on the medication list. And, when you're starting an anticoagulant, there's so many things to talk about, about how to take it and, safety precautions and those kind of things. Really, getting that good, medication reconciliation is the first step. And then, once you kind of get past that, where they, have no apparent indication or potentially have some bleeding risk, like a history of, we did have some patients with a history of peptic ulcer disease, renal disease, uncontrolled hypertension, things that you kind of start to worry about, what's their baseline bleeding risk as well while they're already, starting to stack up drugs. And so then finally, yeah, the multidisciplinary nature of it is, communication. We found is both, shared decision-making with the patient, but communication with the care team. It's amazing how complicated patients have become, now with following with vascular surgery, cardiology, interventionalist, EP, and try to bring all these people. So in our clinic with the DOACs, we don't have the benefit of the anticoagulation clinic that really serves as a coordination site, as with the DOACs, that some of the patients are followed at the University of Michigan on the DOACs, and the anticoagulation clinic is able to step into that role and do some of that coordination. For the patients not being followed on DOACs, though, it's, the prescribing doctor then has to kind of, do some of that work to coordinate with the team and try to determine what's best for the given patient.
Jordan, I may step in and add, Andrea, I think your question is such a good one, right? And for our members, many of whom are working in anticoagulation clinics or managing anticoagulation clinics, this is a really great opportunity to embark on a QI project. And I think the best advice I could give is start small, right? Pick one small area. You don't have to do all of aspirin or all of antiplatelet therapy. Start with just the lowest hanging fruit, right? People who are on an anticoagulant and have no clear indication for aspirin therapy. Let's start by identifying them and seeing if we can get the prescribers and the patients to agree to deprescribe. Once you've sort of gotten yourself going there, you've gotten some good activity, then maybe you take on that next step. Maybe the person with a remote history of CAD or something like that. But I would say start small, start where everyone agrees to this, get that buy-in from all your different clinical groups, and then watch it grow over time. That's probably the best way to approach it.
Yeah, and I was just going to extend upon that thought. I think that if everybody owns it, nobody owns it, right? And so the question has kind of been, the anticoag provider says, well, it's not up to me, it's up to the primary care provider. The primary care provider says, well, it's not up to me, it's up to the cardiologist. And the cardiologist says, I signed off on this case 3 years ago. And so I do think that this falls to the purview of the anticoagulation service to navigate, and it's something that we should consider kind of our job. I want to ask one more question about the study, if I could. What was the most frequent site of bleeding in patients on the combination of DOAC plus aspirin?
Largely gastrointestinal bleeding. We also had cutaneous, bruising kind of issues, hematomas.
Yeah, Arthur, I'll jump in there. I think one thing that was a little different about this analysis, this DOAC plus aspirin analysis, than in our warfarin plus aspirin analysis a few years ago, is that the real driver of fewer events was in not the major bleeds, but the non-major bleeds, right? But I think as anticoagulation providers, we know that those are just as important to patients, right? Whether it's a nosebleed or somebody who cuts themselves, maybe they ran into their door and they can't get it to stop bleeding and it's bleeding for 30 minutes. I mean, those are still distressing. Those are still very concerning to patients. And so anything we can do to reduce those, I don't think we should undervalue it just because it's non-major. I mean, these are still important to patients. And so strategies like this to help prevent them, I think, are worthwhile.
Yeah, and thanks, Jeff, for pointing that out. The major bleeding difference also struck me as well. That's kind of different than what we've seen before. Do you attribute that to the overall better safety profile of DOACs, or is the reason that was seen unclear?
Jordan, do you want to take that? What are your thoughts?
Yeah, so I think, right, most of our differences we're seeing in, as Jeff mentioned, in kind of these more non-major bleeding events. We didn't see as much of a difference in the major bleeds. It's something that will continue to evolve as this cohort is followed over time and expands in size.
Yeah, I think there's two potential explanations. I mean, we know that overall the DOACs are safer, certainly in the most serious. I mean, I'm thinking intracranial hemorrhage type bleeds. And so that may be playing a factor here, but also this is just a smaller study. It's about half the size of our warfarin study. And so there may also be a little bit of a power to detect a difference piece that plays in here as well. So we'll continue to follow and report back.
Dr. Schaefer, in the study, when you were using the aspirin, what dose of aspirin was it? Was it the 81 or 325? Did you guys track that at all?
Yeah, that's a good question. 90% in our matched cohort, and also, similar to the unmatched, 90% of patients were on low dose aspirin, which we defined as under 100 or under 100 milligrams. There were 10% of patients on higher doses.
And following up on that, we've actually had several questions.
There...
Oh, I'm sorry, Andrea. Yeah, there's a little bit of a delay. I apologize. Go ahead.
Oh, no, that's okay. No problem. Is there ever a reason to continue a patient on high dose aspirin in combination with the DOAC?
So there's going to be, I think there's going to still be some subsets where patients will be remain on combination therapy, whether that be, combination of patient preference or unique clinical factors, especially, and then also, there's still some need for additional knowledge, and especially in the, high risk or even, with some patients with various overlapping risk factors.
Yeah, Andrea, I'll jump in on that. I struggle to come up with good indications that are evidence-based to say you need to be on 325 of aspirin instead of 81, especially if you're also being, on an oral anticoagulant. I know that sometimes our cardiac surgeons like to use 325 shortly after surgery, be it with a, bypass surgery or something. And there may be a few other indications, but I think as anticoagulation providers, one of the things we can do is ask that question respectfully, but on behalf of the patient. Why is this person on 325 of aspirin? Is that really necessary? Could we reduce to 81? Or could we stop it altogether and really try to reduce the risk of bleeding? I think that's a really important question that we can do to help support our patients.
Yeah, the data doesn't really support much of a difference in efficacy between 81 and 325. So, right, that is something we could look at a little bit more in our population, is because it's still a sizable number that we're on higher doses that without, and we could kind of explore a little bit why that is.
I may be the only one on this old enough to have lived this this conversation of the dosing of aspirin, but there are data that suggests that 30 milligrams of aspirin is enough to inhibit every circulating platelet. Back in the earlier days of stenting, 325 was the right dose for stents, and that has since changed. There was some back in the PAD days when clopidogrel was trying to get a foothold. For PAD, there was, after Capri trial, there was suggestion that PAD patients are aspirin resistant, and that maybe they need a higher dose, or better yet, a different drug that was branded at the time. Who knows what's real? I would argue, though, that half of 325 is twice as much as 81. So there's probably never an indication for more than half an adult aspirin, much less 4 times the dose we usually use. So.
Yeah, we did find that we did study, when I was in medical school, we studied aspirin resistance and found that a lot of it was non-compliance. The patients that were billed as aspirin resistant, we test, post a dose of aspirin and show, an observed dose of aspirin, acetylated all their platelets on aggregometry. And, they were, when they came into the hospital, when we tested them, they just hadn't been taking it.
Yeah. I'm also not sure when I became the old guy on the webinar. This happened all of a sudden. My goodness.
It's because you have the least amount of hair, Arthur.
I've had that since I was 23. Why don't you go ahead with another question, Andrea?
Yeah, sure. So we had a question come in on the question and answer box to discuss the use of anticoagulation and aspirin in patients with a valve replacement and patients with coronary disease. Do you consider this a standard of care? Do you use this in everyone? Do you have a way to select patients that benefit from combo versus the use of monotherapy?
Yeah, I'm happy to take that, Jordan, that's in my wheelhouse in cardiology.
As a cardiologist, yeah.
Yeah, Andrew, that's a great question. And I think it's a good question because the field is evolving. We used to have recommendations that any patient with a mechanical valve replacement needed to be not just on oral anticoagulants, but also on aspirin therapy. but and Arthur loves to talk about this. This is really based on some older data. Obviously, this is going to be warfarin data, but this is data with different types of valves than we're using today, different surgical techniques, this, that, and whatever else. Actually, the most recent guidelines from ACC/AHA have de-emphasized the use of aspirin in patients who are getting a mechanical valve replacement. It's no longer an across-the-board recommendation. So for me, as I'm seeing patients now, especially patients who've maybe had a more recent mechanical valve replacement in the last couple of years, those are obviously going to be patients who are getting warfarin, not a DOAC. But I'm going to really think hard about whether they need that aspirin therapy. And frankly, for many of them, we're going to talk about de-prescribing and de-escalating the intensity of their antithrombotic therapy to try and avoid the bleeding complications. Because of course, once you have a bleed, it revs up your body's thrombotic system and you can run into other complications. So often they're going to be better off with simply using warfarin therapy. Now, if you switch gears and you say, okay, what about the bioprosthetic valves? So now we're opening up into the DOAC space. Again, I think the data here would say, if you have a clear indication to be on anticoagulation, maybe you have AFib, maybe you had venous thromboembolism, anticoagulation is probably safe and effective, even if you've had a bioprosthetic valve. I don't know that you're necessarily adding a whole lot more by adding in aspirin in that case as well. So I tend to apply the same rules there, but I do so usually in conversation with the cardiac surgeon, just to make sure that I sort of get their blessing to say, yep, it's okay to just be on treatment dose anticoagulation for those patients.
So there's a question that's been plaguing me as well that we've received. So if we know that warfarin for AFib plus aspirin rarely indicated. We now know that DOAC for AFib plus aspirin rarely indicated. There's two components that we might need a little bit more clarity on. One is patients on therapeutic anticoagulation for VTE. Would we apply the same criteria of aspirin likely not indicate? Is there any reason to believe we wouldn't? And then the creme de la creme for patients who are on reduced dose, secondary prophylactic dose, preventative dose of a DOAC long-term, say they have stable CAD, is the DOAC at the reduced dose enough?
Yep, those are two great questions, and definitely in areas where we continue to need additional data. I'd say for VTE in general, and what we saw in our study data is that they tended not to have the same cardiovascular risk, and so there tended to be even less reason for them to be on aspirin. Those tended to be that low-hanging fruit where that might be a otherwise healthy 50-year-old that have been on taking their aspirin for primary prevention. They go to the ER, get a DVT, and then the anticoagulant gets added, and nobody ever discusses the aspirin. So it might not have all the other vascular risk factors as the atrial fibrillation. Those patients, though, what I've seen clinically in my practice too is just some patients did have a good reason to be on aspirin, say for secondary prevention or something else. The aspirin, if they're treated transiently for a DVT for like 3 to 6 months, say a provoked DVT, if the aspirin gets stopped, it's just also important that somebody's, telling that patient that they need to be back on the aspirin then, once, if they have a good reason for it for secondary prevention or something like that. For the reduced dose, that's a discussion we've had a lot as well. We didn't have enough, power to really explore that in this analysis. And I think the Compass trial, showing that low, very low dose with aspirin in some patients may have some benefit, does raise this question of, is there, a sweet spot, so to speak. Jeff, I don't know if you have any other thoughts on.
Yeah. I'll just add briefly, in our DOAC paper that we discussed here, roughly 20% of the group had a reduced dose of DOAC. About 80% had the full dose. Now, usually what that means is somebody with AFib, instead of being on 20 of Riva, was on 15, right? Or instead of being on 5 twice a day of apixaban, was on 2.5 twice a day. That's usually what you're going to see. But I think Jordan brings up the other interesting point, which is, what do you do for the patients who are on the very low dose, sort of the Compass trial data for rivaroxaban. And obviously in that case, it was meant to be combination, very low dose riva plus low dose aspirin in a dual pathway inhibition. So that's sort of set to the side. That's indicated for both. But I think if you have a slightly reduced dose because of renal function, we're doing that because it gets you to similar, effective therapeutic doses of anticoagulation. It's reasonable to take a same aspirin deprescribing approach, but more data would certainly be useful in that space.
Yeah, I think that dose reduction for patient-specific factors is still therapeutic anticoagulation, but the secondary prophylactic dose for VTE specifically is where we don't really know. That's the head scratcher for me.
How long would you typically recommend? So say a patient has AFib, they're on the DOAC, they have a new MI. How long would you typically recommend, continuing the dual therapy until we de-escalate? And of course, including Plavix initially, but what would be your kind of typical de-escalation process?
Yeah, Andrea, I'm happy to sort of answer this one from a cardiology lens. So there's a couple pieces that play in here, right? Anyone who has an MI, we would consider having an acute coronary syndrome. So the guidelines would say on its own, that person has an indication for dual antiplatelet therapy, a P2Y12 plus aspirin, for 12 months. But we know from a number of trials, probably the best and most robust being the Augustus trial, that if they also have an indication for anticoagulation, so they're on a treatment dose anticoagulant, it makes sense to de-escalate from triple therapy down to dual therapy as soon as possible. And in fact, there was a nice secondary analysis from Augustus showing that the 30-day mark is usually the point at which you're not really going to get a whole lot of additional benefit from triple therapy. So when I see a person who's on an anticoagulant, maybe it's for AFib, and they have an acute coronary syndrome, often we're going to put in a coronary stent. What I try to do with my team is say, we've got to get triple therapy reduced to simply the anticoagulant and the P2Y12 inhibitor no later than 30 days. Sometimes we can do it even sooner, maybe before they leave the hospital or after a week. I'll sort of talk with the interventionalist about that. But certainly we got to stop aspirin by 30 days. And then we'll continue the P2Y12 inhibitor for up to a year if it's an acute coronary syndrome patient. If it's somebody who's just getting a stent because of, let's say, stable angina, we'll often stop the P2Y12 inhibitor even as soon as 3 months and then get them back to just single anticoagulant therapy. So it kind of depends on what their acute coronary syndrome or their coronary presentation was like. But really, we're trying to shorten these, fewer drugs, shorter durations, get them back to single oral anticoagulant therapy as soon as we can to avoid the bleeding risk.
So what you're addressing there actually gets to one of the points that I thought about with this study, which is you kind of defined, it seems that you kind of defined stable CAD as no MI within the last 6 months. If you look at the prior guidelines about stable, stable CAD, they typically use a year, no MI or revascularization for a year. And so what you're getting at kind of points to that, but I don't know that that's universally adopted, that there's, I think that folks tend to think that there are these extreme examples where we would use antiplatelet plus anticoagulation therapy less than a year. And it's basically the patient has to be having major bleeding. So it sounds like this may be a moving target that we, as our anticoag colleagues, need to really be up on.
Yeah, Arthur, and I'll just emphasize that by saying, remember that guidelines are guidelines, they're not rules. And so they're meant to sort of help us start in a place to think about what's best for a patient, but we have to consider that individual patient's situation, right? So when I see somebody who's on an anticoagulant, let's say for AFib, and they undergo, coronary stenting because of an acute coronary syndrome, I start by saying anticoagulation plus P2Y12 for a year. But if this person has had 3 GI bleeds in the last 2 months, boy, maybe I'm going to sort of pull that back and say, can we get to a shorter duration? What else can we do, right? If I'm talking to my coronary interventionalist and they say, this guy had the most complex intervention I've ever seen, I'm really worried these small, long stents are going to thrombose. Well, maybe we do have to give a little bit of extra antiplatelet therapy in that person if their bleeding risk is manageable. But the guidelines sort of help us start, and then we personalize from there.
Kind of along the same line of PCI, we often see not only this in practice, but some of the guidelines actually support using reduced doses of DOACs when patients are co-prescribed in the setting, antiplatelets in the setting of a PCI. What are your thoughts on that? Should we be dose reducing because of the risk of bleeding, or should we be following renal dosing guidance in these cases?
So I think what you're getting to there is, so for instance, in the rivaroxaban and dabigatran studies where they used a reduced dose of those DOACs in addition to the antiplatelet therapy for those patients, and compared it to sort of a more traditional triple therapy with warfarin. And that's certainly the regimen that was used. Obviously here in the US, rivaroxaban is used much more than dabigatran, so that's kind of the one we're thinking about. But I would point to the Augustus trial again. This was the largest, the most robust study, and it used the regular treatment doses of apixaban. And so in my mind, I want to be sure that that patient is getting appropriate stroke prevention in atrial fibrillation. And then if I can reduce the bleeding risk by stopping aspirin and keeping them just on clopidogrel, and then shortening the duration of that, that seems to be the best approach possible. So that's where I usually start. I'll be honest, if I'm going to use Riva or Dabi, I tend to use the full treatment dose, and I realize that is not following the way those clinical trials were designed. You have very good justification to follow those clinical trials. But for me, I feel like if I'm purposefully giving an anticoagulant to prevent stroke in AFib, I want to use the stroke in AFib dosing for those patients. So I realize I'm a little bit off label, off trial there, but I think it's a reasonable approach.
Well, and I agree with you. The problem is that if you just take those trials at face value, you have to realize those trials did not study, they studied an AFib population without studying AFib outcomes. And so for us to dose reduce in an AFib population because of risk of bleeding when they didn't study stroke outcomes or AFib outcomes is spooky. I agree with you.
Dr. Schaefer, just to change gears just a little bit, we had a question come in about race and ethnicity, and were there any differences that you found in the trial when you compared aspirin use with some of our minority racial groups?
That's a good question. It's not something that we didn't match for that, and we didn't really compare our outcomes, based on race and ethnicity. We do have a very diverse patient cohort that's representative of the state of Michigan. We have clinics throughout the state included. It's something that I have looked at in venous thromboembolism before, and have looked at in other studies. There definitely do seem to be disparities in anticoagulation and antithrombotic management. And, it's sometimes, I think it's understudied and something that we need to be paying more attention to in terms of, what kind of resources, education, access to providers, access to, some of these, quality improvement measures, and as far as, getting patients to the right drug. I think there's probably some disparities out there that are need to be addressed.
So we had a question back to the study. Do you know how long patients were on aspirin prior to the study period? I think the thought here is that, and this could apply to anticoagulation therapy too. We know that when we give antithrombotic therapy, that if a bleed's going to show up, it tends to show up early. So the question is by allowing kind of lead-in periods with antithrombotic agents, did we potentially rule out potential bleeds?
Yeah, so when patients are enrolled into the registry, they're asked about aspirin use, and it's captured in follow-up so we can get a trend. And we did include patients that had switched from warfarin to a DOAC that had a little bit more of that anticoagulation track record. Again, about 1/3 of the study population. However, we don't have the data on the aspirin run-in. We have some sense of the anticoagulant run-in, but not aspirin.
So some questions have come in regarding, these patients that get put on the primary, aspirin regimen, and then they end up on a direct oral anticoagulant, patients like our diabetics, or someone has like a calcium score that comes back high and the cardiologist puts them on a preventative aspirin and now they're on a DOAC. And so, what do we do with those patients? Do we continue to de-escalate them as soon as we start the DOAC, or do we consider if we need to continue aspirin?
Yeah, so this is something that's come up, in this primary prevention population, and as we've made these interventions, worked on some of these interventions to reduce excess aspirin use, that some patients, do have these other risk factors like coronary calcium scores or strong family history, or also just kind of a cultural kind of attachment to the aspirin, where they said, my dad took aspirin and he lived to be 90 and I'm going to take aspirin, or, I saw it on the commercial that I should be on the aspirin and I'm going to be on it. And so even some patients that were deprescribed aspirin and went through the shared, with their doctors, talked about pros and cons, came off the aspirin, they later went back and restarted some of the aspirin at a later time because they just have that, that perception that the aspirin's going to help them and it's over the counter, and, they perceive it as no risk and don't really recognize, that they could land in the hospital, with a major, bleed that could be even, life-threatening. And so, I think for the majority of the primary prevention, and in looking at the American ACC AHA guidelines on aspirin for primary prevention, I think there is more of a shift to try to deprescribe for the primary prevention indications, but there's always going to be that situation. And, this study does give us a sense of the magnitude of the bleed risk. And so it's something that you could bring back to patients and say, if you feel more comfortable, on the aspirin, this is probably about the magnitude of the bleeding. What else can we do to reduce your bleed risk? Do we need to look at gastrointestinal prophylaxis or, other medications that you might be on, those kind of things?
Definitely. There's a lot of push, from Bayer and such with, a lot of commercials I've seen, and, they really push, for patients to be taking these things. And so I think it's just really important that we complete that MedRec. I found personally that a lot of my patients, if they don't bring their meds with them, they may not even consider aspirin to be a medication. And so, asking them, are these, even if they bring all of their pill bottles, are these all of your medications? Do you take anything else over the counter? And I do make it a habit to ask them, are you taking any aspirin? Do you take any Aleve, any ibuprofen, any Advil? Do you ever take it? Do you take it now and then for a headache? What's your pattern of taking these medications? And so we can provide the education.
We have really a lot of questions that are trying to zero in on who should you continue it on. I think that we've addressed low-hanging fruit of primary prevention. There's just no good reason. The second best data, I think, comes from stable CAD. I think that question has kind of been asked and answered pretty well. But are there other indications in which we should not touch the aspirin or make it a specialist call? And specifically, there's a question that comes up about, back to the CAD, about should we be treating CABG differently than PCI?
Well, I'm happy to start with that. There is sort of a thought, and I think it's based on some lower quality data, that perhaps patients with CABG get a little bit more benefit with being on antiplatelet therapy and keeping, especially the vein grafts open. And so I'm willing to have a conversation, at least in the short term after surgery, but once those vein grafts have been open for a while, whether it's 6 months or 12 months, at a certain point, I think it's extremely reasonable to say perhaps we would back off. It's a conversation to have with the cardiac surgeons and come up with a practice pattern at your center. The other group that I think of as being extremely reasonable and maybe even strongly indicated to be on anticoagulation plus aspirin would be some of your high-risk antiphospholipid antibody patients. Those who've had recurrent thrombosis, arterial thromboses, pregnancy losses. Those are another group of patients in whom sometimes more is helpful. And so those are at least two places where I would start.
Yeah, that's kind of my experience as well. You know, some of the myeloproliferative disorders that I see, patients that have failed anticoagulants, clotted on anticoagulation. You know, there are some patients in arterial events or even, you know, superficial, SVTs while being on anticoagulation, those kind of things. There still is some patients that there's going to be a role for potential combination therapy, at least until more data is available in the setting.
Yeah, I would add to that aspirin as an option in patients who quote unquote fail anticoagulation therapy, specifically valves, specifically back to APS as well. Just pushing the INR range isn't always the answer. Going to an approach with a different mechanism probably makes sense. What about, Jeff, other vascular beds though? Do we have enough data in, carotid disease, cerebrovascular disease, PAD spooks me. Do we have enough data to really think that oral anticoagulation is enough in those cases?
Yeah, it's a good question. And I don't know. So certainly in the cerebrovascular space, we've seen that when we can't come up with a source of embolism, anticoagulation is not the answer and antiplatelet therapy may be better. But if you know that you have AFib, then sometimes it can be hard to say, are we really sure that this is unknown source where we're on anticoagulation alone? So I think that's a place where anticoagulation is often helpful. In the lower extremities, PAD or venous disease, that's where there may be some good reasons to be on combination therapies. And you need to really work with your interventionalist to understand those and come up with some good protocols at your health system.
Okay, well, thank you so much. Thank you to all of our speakers, Jordan Schaefer, Jeff Barnes, Arthur Allen, and Andrea Van Beek. Jordan, thank you so much for your wonderful presentation. And Jeff and Jordan, thank you for your research on this important and practical topic. I want to particularly thank Andrea Van Beek, who is a new AC Forum board member and has joined our webinar team. Welcome, and thank you, Andrea. You did a great job today. As usual, this webinar has been recorded and will be posted on the AC Forum website in a few days. It is accredited for physicians, nurses, and pharmacists, and you can claim your credit at this link, and Ashley also just put it into the chat. We hope that you will all attend or think about attending our national conference. It's being held in October in San Francisco, both in person and broadcast virtually. All attendees will have 30-day access after the meeting, so we hope you will join us. I want to share a very exciting new tool from the AC Forum. It's called our Literature Update. This new website allows you to stay up to date on the most relevant and important published papers. You can search by topic, review the abstracts, see which papers AC Forum thinks is most important. So we hope you will all look at this tool. I'd like to thank AC Forum board member Bishoy Raghib for curating the literature every 2 weeks, and to Elaine Whalen for helping make this website happen. We also are creating something called a rapid recap, which will highlight the 5 or 6 most important papers in that month. And again, that will be published monthly. And you can find both of these tools in our Centers of Excellence Resource Center. So with that, thank you all for joining. I'd also like to thank our corporate sponsors for their support. Have a great day.